is about.
Dr.
So
Ali,
the first debate is about functional versus structural assessment of coronary artery disease. Dr. Ahmad Alkaisy will do. Are you doing functional, Ahmed, or structural?
Functional.
So Ahmad Alkaisy will do functional, and Samer Noaman will do structural. Ahmed, we'll start with you. If you wouldn't mind, go ahead.
Thank you very much. Thanks, everyone. Good evening, everyone. It's lovely to be here. I'll just share my slides.
If you wouldn't mind, before we start, everyone should be muted, if you wouldn't mind. And if you have any questions, you can feel free to write it on the chat, and we'll ask the speakers at the end. Thank you.
Doctor, can we start by introduction? If each of our colleagues start introducing himself and area of interest or work.
Yeah, that's fine. Ahmed, we'll start with you. Go ahead.
Yeah, so my name is Ahmad Alkaisy. I'm a consultant cardiologist and electrophysiologist, Royal Melbourne Hospital and Western Health. I've done my training in Melbourne and work in my heart cardiology. So my particular interest, what I do every day is electrophysiology. So I do a lot of pacing, a lot of ablations for AFs and stuff, and look after general cardiology.
Samer.
Thank you, everyone. My name is Samer Noaman. I'm an interventional cardiologist, just like Dr. Ali, just like Dr. Omar, who joined the meeting. I do coronary interventions and structural interventions and general cardiology, just as usual, working in multiple places.
Excellent. Thank you very much. So the slides, everyone seeing the slides, I hope? Yes?
Yes.
Excellent. All right, Ahmed, we'll start with you. Thank you very much. Go ahead.
So I was asked to talk about, to have this debate with Samer about functional versus anatomical testing for coronary artery disease. And I mean, it's despite the fact that I don't see a lot of patients with chest pain, we do see a lot of patients in general cardiology. They still come to us and we still have to make decisions about. So I thought I'd start with functional. I just wanted to have, I don't have many disclosures, but one disclosure to make, which is despite knowing Samer for almost a quarter of a century, going through med school together and moving to Australia, going through the BPT, cardiology, and then ending up in the same health service, in the same practice doing cardiology, albeit different subspecialties. My opinions today are mine and they're not influenced in any way by Samer. All right. So in patients who present with stable cardiac symptoms, and I want to stress on the importance that this is stable cardiac symptoms, patients who have an acute coronary syndrome, chest pain, troponins are investigated in a different way. But if you have stable cardiac symptoms, usually non-invasive testing is the first test to think about. There are several options, really dependent on where you are and where you practice and what's available. And it's very hard to sometimes to decide which one is which, and that's why we're having this debate. So broadly speaking, we divide them into two types of tests. One is functional and the other one is anatomical. Functional is basically what you're trying to do is you're trying to assess the coronary blood flow during stress and to try and look for ischemia. And we do that either most commonly using exercise, or in patients who cannot exercise, we give them drugs to increase, their heart rate or cause vasodilation to increase their cardiac workload. And then the modalities that are available are stress echocardiography, stress myocardial perfusion scan, and more recently, stress cardiac MRIs being available. On the other hand, you've got anatomical testing, which allows you to have pretty much a direct visualization of the arteries to assess any narrowness and also the severity of it in addition to the calcium score. And that's usually represented by the CT coronary angiogram. Stress echocardiography being kind of treadmill is pretty much the most common non-invasive cardiac test that we kind of perform apart from transthoracic echocardiography, and it's designed to look for wall motion abnormalities at stress. Basically, patients come in, they would have a baseline study. We put them on a treadmill, we push them until they can't go on or develop symptoms to usually about 85% of the maximal predicted heart rate. And then we do an echocardiography scan afterwards to determine if there are any wall motion abnormalities at stress compared to at rest. It's easily accessible, pretty much it's widely available in a lot of cardiology practices, cost effective. And in patients who are unable to exercise, we usually use dobutamine as a mean to increase the workload. And the only particular one where it gets tricky is patients who have large body habitus, where it becomes really challenging to get those echo imaging. So in these patients, we cannot get any meaningful echo images because of their body habitus. We often prefer them to have a nuclear stress test or a perfusion scan, and it's basically designed to look for perfusion defects. So it's really for the patients who you cannot do an echo, or the echo is not going to be enough good images. However, it's required to be done in a radiology service. Stress cardiac MRI is becoming more and more available. It's still harder to access, and basically it looks at myocardial perfusion at stress. It's more accurate estimation of the ejection fraction, but it's not, as I said, there are selective radiology services that do it. So why do I like functional testing as opposed to anatomical testing? I feel like in addition to knowing what the patient has, problems with their coronary artery or inducible ischemia, a stress test or a functional test allows you to baseline assess the LV function and the valvular function. In addition to that, it allows you to really kind of assess or do a functional assessment on the patient's exercise capacity. And we know that exercise capacity or functional capacity is really tied very closely to, longevity and survival, even in patients who have, coronary artery disease, even in patients who do not have coronary artery disease, exercise capacity is long tied to their longevity. It also allows us to do a functional assessment of the systolic blood pressure and pulmonary artery pressures to investigate patients who have, unexplained breathlessness. It doesn't have to be ischemia. And also assessment of any inducible heart rhythm disorders. And all of this information, because we stress patients, we're able to get that information. Now, a few head-to-head kind of studies have looked at, have used, registry-based data looking at differences between a functional testing versus a anatomical testing strategy. And several studies have been done. And the thing that we see over and over is if you start off with a CT coronary angiogram, you'll end up with higher rates of aspirin and statin and mostly treating lesions that are not really significant. Patients who have a CT coronary angiogram are more likely to end up with an invasive coronary angiogram. And this is, of course, associated with healthcare costs. Now, you do wonder if I'm doing a CT coronary angiogram and picking up those 20-30% lesions that would be negative on a stress test, I'm probably doing a good thing because I'm putting them on statins, I'm putting them on aspirin. But the answer so far has been no, where those patients, when they're compared and followed up in the longer term, their overall mortality is pretty much the same. There is a signal, however, towards less acute coronary syndrome, but the heart endpoint, which is overall mortality, is pretty much the same. So to summarize, functional testing, especially stress echocardiography, is pretty much readily available. It's cheaper, and it provides a functional assessment of ischemia in addition to other aspects, other hemodynamic aspects that would be useful in our clinical decisions. And importantly, it's similar outcomes to an anatomical assessment with less aspirin, statin, and invasive coronary angiography. All right. That's it for me.
Excellent. Look, thank you very much, Ahmed. That was right on time. Now we allow Samer to upload his slides and start the debate.
Thank you. Can everyone see my screen?
Yep, we do.
Perfect. So just wanted to show you this one. Start with this one. This is exercise stress echo that Ahmed spoke about. You look at the heart myocardium and you assess whether it's contracting well or not. So obviously there's a lot of assessment that gets done into it. And here you can see the anterior wall, which is here, the top of the donut, is not contracting very well, and that's a positive stress test. At best, a stress echo is about 80 to 85% sensitive and 84 to 86 specific. That sensitivity and specificity by far surpasses exercise ECG, which I have not done for the last 10 years, and I have never referred anyone for a stress ECG because it's not good enough. But again, that sensitivity and specificity, whenever you refer a patient for a stress test, just remember it's not a perfect test as well. Lots of limitations. One of the major limitations for healthcare professionals is the fact that Medicare only approves it for non-specialists to be referring a patient every 2 years to the day. The indications are chest pain, shortness of breath, preoperative assessment, abnormal ECG, and known coronary artery disease. It doesn't allow much for asymptomatic screening. Now, you have now anatomical delineation with a CT coronary angiogram, as well as a calcium score, which is obtained through the CT. The difference is that the calcium score is without contrast. The CT angiogram involves contrast. The test takes 10 minutes. For calcium score, there's no contrast. The radiation dose is minimal, and it is ECG gated where the patient is hooked onto an ECG machine. This is an example of a non-calcified artery on the left versus a calcified artery that appears bright. Based on the density and the area occupied by that calcium, we get the calcium score. And it's quite helpful because studies have shown with different levels of calcium score, the risk of coronary events over 5 years, and sometimes extrapolated over 10 years, is different. So if you have a calcium score of 0, your risk of coronary event is minimal. If you have a calcium score of up to 100, your risk goes up. And if yours is above 300, some studies 400, your risk is extremely high. If you're thinking about this one, a calcium score more than 300, the risk is about 5% or 6% over 5 years. It's quite significant. So it's quite helpful in terms of primary prevention to get a calcium score. The Cardiac Society adopted calcium score a bit later, and Medicare hasn't adopted that at all. The limitation is that the patients have to pay for it, and the prices keep going up with time. I think it's up to 300 in Melbourne now. Luckily, Vision Radiology offers a bulk billing service, but they still can't bulk bill a calcium score because there's no Medicare rebate. So for patients who are symptomatic, ideally send them for non-invasive stress test because then you can identify whether their symptoms are related to ischemia or not with exertion. Patients who are asymptomatic are best suited for further characterization with a calcium score, and it works mostly for low risk and intermediate risk individuals. And that's based on whatever risk calculator you use. For high risk individuals, calcium score is not going to be helpful because what calcium score is going to tell you is that you need a statin and you need an aspirin if it's high. But if you're high risk clinically, then you don't need a calcium score to tell you that. So it can refine risk stratification a bit better in the low and the intermediate. Here are images of a coronary angiogram, not of a calcium score. What it does, they inject a dye into the artery, it transmits into the coronary arteries, and then the scanner, you can reconstitute the arteries to demonstrate the tree. The extremely bright bits are calcium, the rest is the anatomy. So that's why it's an anatomical delineation. Sorry, I'll just mute this for a sec. Apologies, I'm at the hospital. So on the left-hand side, you'll see the reconstituted images of the CT, and this is how we report CT coronary angiograms. That's how it looks. The first panel here is a minor stenosis. The second panel here is a mild stenosis, 10 to 50%. Technically, it should be reported up to 49%. But you can see it's not that accurate. When it gets more to the severe end, so this is 50 to 70, this is considered moderate to severe. This is a severe end more than 70%. It becomes more conclusive. So it's very helpful in the severe, in the two ends, normal or very mild versus severe. In the middle, you might still need to confirm whether it's functionally significant or not with a stress test, for instance. The CT coronary is rebatable by Medicare up to 5 years. Otherwise, patients pay $850 for it. The indications are chest pain, an equivocal stress test, or unable to perform stress test. They can't exercise, or if you want to exclude coronary anomalies, particularly young patients with family history of premature death in the first-degree relative, and perioperative assessment for non-cardiac surgery. A lot of these patients might be limited in terms of exercise, so it's helpful. All roads lead to Rome because after doing a stress test or after doing a CT coronary angiogram, you want to confirm the findings with an invasive coronary angiography. This is the cath lab setting. Please ignore the extremely handsome cardiologist there. I just took this picture at Sunshine Cath Lab 2 minutes ago. Invasive coronary angiography gives you a definitive assessment of coronary anatomy as well as coronary flow limitations. This is an example. 62-year-old man with an exertional angina. On the stress test, they demonstrated inducible ischemia, has got multiple risk factors. He had a positive stress test used. Then you need to refer him for invasive angiography, which is the most accurate anatomical delineation with a spatial resolution of 0.5 millimeters. So you can see most of the epicardial vessels. And this patient here has severe disease in the LAD. This is another case, 56-year-old, sorry, that one skipped past. Let me see. 56-year-old with exertional angina. This time it was sent for a CT coronary and showed a severe proximal LAD. You see that black line at the start of it, there's a very tight lesion, and that's actually a severe proximal LAD disease that can be fixed with a stent. This is another case of 58-year-old asymptomatic person, screening with a CT coronary angiogram. They had to pay for it, showed moderate to severe circumflex as well as LAD disease, and you still need to confirm. This one, the LAD looks like a 30%. The artery is down the bottom right side. That's the OM, and that confirmed severe disease. So you still need confirmation if you suspect the patient has disease. So for a comparison of stress echo being the perfect example of non-invasive test versus CT, which is a good example of a non-invasive anatomical test, there's good comparisons. Having said that, the sensitivity and specificity are the same. So I'm less likely to refer for a CT angio if they're female, because there's a bit of radiation dose to it, especially if they've got history of breast cancer or family history of breast cancer. I'm less likely to refer an older person for a CT coronary angiogram because they do have calcifications that limit the luminal severity assessment. So younger patients is perfect for that. Stress echo does not involve any contrast. It's cost effective. It's widely available, but the image quality can be limited, particularly in the obese patients. And if their baseline echo says difficult imaging, then don't refer them for a stress echo. You can refer them for a CT. The cost is much lower for stress echo compared to CT. The rules are the ones that govern what you're going to refer to, because as a non-specialist, you're not allowed to refer for a CT coronary angiogram. It's ridiculous. As a specialist, you actually don't have to be a cardiologist to refer for a CT coronary. A palliative care physician can refer for a CT coronary, which is ridiculous as well. So these are the limitations. I think most of the limitations are logistic. The fact that you assessed cardiovascular disease risk is a big bonus, and I think using either modality is good.
Attention, please. Visiting council and
Apologies.
cooperation in your area at this time.
The only thing
Certainly appreciated.
The only thing I would say is that do not refer for stress MEB scans unless the patients cannot exercise and they don't have a good imaging capacity and you cannot get them a CT coronary. Thank you.
Excellent. Thank you very much. Right on time. So we understand functional assessment and structural assessment, they go hand in hand. Every test has its own limitation. We always get caught with a calcium score of 0 and severe coronary artery disease, mainly in the younger population, and a negative stress test with severe peripheral vessel disease, and they end up having bypass surgery. And this is the limitation of these tests. Regardless, you probably by end of the day, you assess the patient you assess the patient by examination, and you're taking good history and decide as which test you go with. Excellent. Now, we open up the floor for questions. We have around 9 minutes, so feel free to raise your hand and ask the question, or unmute and ask the questions. Please, go ahead. If there's any questions. There is a question on the chats from Zina, says, good evening, thanks for the opportunity to discuss the common cardiac problems. I have a questions to the panel. How much do they recommend the lipoprotein little a blood test order in primary health setting? This question is open for both of you, Samer and Ahmad.
You. So lipoprotein little a is as the name implies, it's a lipoprotein, a dense carrier for LDL that sorry, I'm just going to mute for a second.
We can use this time and Ahmad can answer the question if you like.
I usually ask, being a pure electrician nowadays, I usually ask Samer for what is the up-to-date on lipoprotein little a. But I had mine done, and I think you do it for patients who have a very high risk for coronary artery disease, and especially premature coronary artery disease. But Samer will tell us, because there are always going to be new therapies.
So it's highly dense, highly pathogenic if it in abnormal levels, and limited treatment options apart from PCSK9 inhibitors such as the Patha and inclisiran, which more on PBS criteria people don't qualify based on lipoprotein little a. I would personally only test those if a patient has already had an established coronary artery disease through either method of assessment, functional or anatomical, and there is no risk factor to explain why they've developed this disease. So I do it in hospital for people who have an acute coronary syndrome, and they're younger than 55 women and younger than 60 in males who are non-smokers, non-diabetic. The caveat for that being, if you have dyslipidemia with an elevated LDL, lipoprotein will automatically be elevated. So do it in patients with near normal or normal LDL levels. It's very helpful. The second thing, if you want to re-stratify the risk of coronary artery disease, lipoprotein little a and ApoB are two good tests to do as well in terms from a lipid mechanism. And you can do high sensitivity CRP as well. These are non-invasive ones. These are non-rebatable, and patients have to pay for it with limited treatment options, and you'll be stuck if they're elevated, or you'll be referring them for a cardiologist assessment as well. So limited role, but an evolving field.
Thank you very much. There is a question from media. Is there a role for screening CT angio for asymptomatic person with no risk factors? If so, from what age? So this is
Ali,
for
you might be
Samer.
better answering. I can answer that one. I've had mine at age 36 because I have family history of premature coronary disease or cardiovascular disease. There's no set point. There's no real guidance. It's not rebatable for asymptomatic disease. There's no good evidence either to do a CT coronary angiogram for asymptomatic patients. My personal recommendation for patients is that if your first degree relative had a premature coronary disease, unexplained for risk factors, I would recommend doing a CT angio for the patient or for the client 5 years prior to the age of their first degree relative. So for instance, someone's father died all of a sudden age 45 or had an MI at age 45, unexplained with no risk factors, and the son who I'm seeing now has just turned 40 and they're healthy, then I tell them that it is not unreasonable for you to have that. Unfortunately, you have to pay for it.
Ali, can I ask a question?
Go ahead.
Yeah. To my knowledge, age is a risk factor for coronary artery disease. The older are you, the higher chances of have a coronary disease affected there. If from our angle in gastro, we started the colonic cancer screening at the age of 50, starting from the reality that the risk of cancer increased with age. And then that proved to be very helpful, very beneficial. And the pickup rate is very high, pickup of early cancer. That's the early stage of that. And nowadays, we drop the screening to the age of 45 within the program and to the age of 40 outside the program. So my point, with the progress of age, do you think there might be a non-invasive screening test you might complement from the age of 60, for example, or 65, considering the age as a risk factors for heart disease? That's for all of you, the question for all of you.
My take on it is cost effectiveness and healthcare systems. So the guidelines are clear about this. You need cardiovascular risk assessment from the age of 20 by your GP. might be an overkill, but it's the number one killer in the world. The problem with it is that the reason they haven't instituted just like colonoscopies for colon cancer is that coronary artery disease mortality modification does not come from stent or bypass for stable disease. Those treatments are standardized for acute coronary syndrome because they change mortality compared to colon cancer. So if someone has a 70% right coronary artery disease stable, the only mortality changing intervention is an aspirin and a statin, which is why they haven't started the screening programs.
And the problem, just to continue on this, there's no specific screening program. You're sending patients for calcium score. If they are in the younger population, the calcium score will come back as being negative. So it doesn't really help. But we know that the cause of sudden death in the younger population is the ruptured plaque that is just 20% or 25%. Inflammations become more and more important now, and we're looking at the inflammation as a risk. The high sensitivity C-reactive protein can be used as a screening, but it's still non-specific, and I don't believe it's we can do it for everyone, and we're able to predict coronary artery disease. There are some more evidence for endothelial dysfunction. So patients at moderate risk, you probably can assess their endothelial function. However, again, endothelial function has been very difficult to assess. Now, I am working on a program or a project using dynamic vessel analyzer, which is a retinal camera that's able to assess the endothelial function using the retinal arteries. Again, this is a test. It's still a research tool. It's not a clinical tool as yet, but we hope that we find something going to the future, and we're able to use that for assessment, for endothelial assessment. So I think the best thing to find is if we're able to, is a blood test, but so far we don't have a blood test we can use as a screening test for underlying coronary artery disease. However, we have risk factors. If we're able to manage risk factors well, I think we'll be able to save lives. Now, there are a few more questions in the chat. Zina Jawad, unfortunately, it won't. As calcium score has more, okay, no. Calcium score demonstrates end organ damage. These are just comments, not questions. Any other questions? There are no questions. We have 1 minute. I'll ask one question. What do you think, Samer and Ahmed, of the CT FFR and why it's not available yet?
Yeah, CT FFR is very interesting. So basically, to the audience, what CT FFR is basically a calcium score. A CT coronary angiogram can show you a 50% blockage or a 70% blockage, but not all blockages are the same, because some blockages might be limiting blood flow, some blockages may not. We only want to refine it to a point that we treat patients with blood flow limitation. I think the CT FFR correlation with the invasive FFR is not as strong, which means if you do an FFR or predict the flow limitation on CT and correlate it with a flow limitation with invasive angiography plus a pressure wire down the artery, correlation is not strong enough to justify it. Although some studies, a bit variable in different studies, and there's different methodology of doing it. But I don't think that it's going to be a deciding factor. And Dr. Ali, I know the evidence speaks that there is an association. For me, I find it hard to predict pressure from an image. It's just not intuitive for me. So I haven't been using that. And in addition, we can send them to Ahmed for a stress test. We can send them to any cardiology practice for a stress test, which can tell us if that 70% is flow limiting or not, which I think is more helpful.
Yeah, look, I think the problem is even with the stress test, that negative predictive value is not very high. It's still 85%. I just, a patient of mine had a stress test which was reported as being negative, done really, really well on the treadmill, but he ended up having an angiogram because he had a CT coronary angiogram afterwards because of the family history, and found triple vessel disease, and he's ended up having a bypass surgery. So even with functional assessment, you still have the negative, the specificity is not that high, so still 85%, and we still miss a few patients. Well, thank you very much. I think this is the first half of the day is over, and we're moving on into the next debate. So we have Omar Almukhtar and Fitoon Yaldo. So we'll start with ladies first. Fitoon, can you present yourself, and then we'll start with your slides?
Yeah, I'll share my slides. I believe you can see it, right? Yep.
Here we go.
Yeah.
Well, tell us about you, Fitoon, for 30 seconds.
Yes, so I'm a cardiothoracic and surgery fellow at the Austin Hospital. And I have no disclosures apart from probably being originating from Iraq. So that's my disclosure and conflict of interest. Go back. Happy for me to start, or do you want me to talk more about myself?
No, just go ahead. You'll start with, so do you want to start with, we'll start with the surgical. So basically what we're debating here, which patient will go for surgical aortic valve replacement or trans-aortic valve replacement. It's not a debate. Every patient has a specific characteristics. Patients who get referred for aortic valve replacement, they should be symptomatic, plus they have underlying severe aortic valve stenosis. Aortic valve regurgitation is still not an indication for TAVR for certain reasons, and this is basically technical and mechanical reasons. So they end up having surgical aortic valve replacement. But for severe aortic stenosis, and probably Omar will argue for these days even moving down to moderate aortic stenosis, if the patient is symptomatic, they will go for aortic valve replacement with a surgical or transcatheter. So I'll leave it with Fitoon to start her presentation. Please go ahead.
So I thought I would talk about the lifetime aortic valve management from our perspective. That would be more related to us as surgeons. So I would focus on my talk on that, and then I'll leave the rest to Omar. So this is not moving. It's moving right now, you can see. Yeah. So
good, yeah. Go ahead.
Yeah. So here, if you look at this slide, we can see that there is a changing pattern of aortic valve replacement in Australia in different age groups. As we can see, TAVR has taken over as the mainstream procedure in those over 75 years old. In those under the 75 age group, surgical aortic valve replacement is still the mainstay, but this may change over time. In Australia, as we know, funding for TAVR is meant to be tied to the consensus decision-making in a heart team. So here, interestingly, if we look at the private sector data, there is a difference in practice. So you can see here there is more TAVR in those who are aged more than 65 years old. And similarly, there is more SAVR in those more than 85 years old. Now, there might be different explanations for that, but it also raises the question of the robustness of the heart team process. So for GPs and primary health clinicians, you are the best place to know the details of the patient, their comorbidities and the frailty, and you will be playing an important role in counseling these patients about their choices. If we look at this slide, we can see that aortic stenosis in clinical practice that we see, it has a bimodal distribution. So we have a peak in those 45 to 60-year-old. And this is largely due to premature calcification in a congenitally bicuspid valve. And also there is then another peak around 70-year plus, which is usually degenerative calcific stenosis in tri-leaflet aortic valve. Why this is important? We need to understand this bimodal distribution because it has serious implication for the lifetime valve management in the younger patient group. This is just some pictures to have a better idea of how the valve looks like. So if we look at this picture, we can see it's a tri-leaflet valve. and this is aortic stenosis in an elderly patient. And then this is pictures of a bicuspid aortic valve stenosis in a younger patient. If we look at this last picture, we can see extensive calcification that's extending into the LV muscle. And if you can also appreciate the annula in the tri-leaflet valve is circular, but here in the bicuspid one is a bit more elliptical. And that's why bicuspid valve, they are not quite suitable for TAVR, though this is also growing and changing. But we know not all bicuspid valve are suitable for TAVR. This diagram is just giving us like an overview of the mandatory role of the heart team for every severe aortic stenosis in the consideration of TAVR or SAVR. So on the right, we can see if the patient is a clearly high surgical risk, irrespective of their age, then TAVR is chosen. And here, sorry, on the right, we can see where palliation is important if the patient has very poor quality of life. If we look at here, if the patient is of intermediate risk, then there's an equipoise between SAVR and TAVR, and age and patient preference comes in. If we have a low-risk patient, younger patient, then of course lifetime valve management consideration will come into play. And in every case, we always do risk calculation based on STS and Euroscore. I'll talk about the SAVR valve choices. So we have mechanical and bioprosthesis. So with the mechanical valves, we know they are the best in terms of longevity. It might be the best option, but as the patient grows older, then this becomes an issue because they will need warfarinization for life. And we know that the PROACT trial has showed that we cannot use NOAC, and all patients with mechanical valve must be on warfarin. The other options we have is the bioprosthetic. So it can either be bovine pericardial or porcine from porcine leaflets. It's usually an excellent choice for those over 75 years of age. But in the younger group from 50 to 65, the issue will be the structural valve degeneration because it will be even accelerated in the younger age group and in the renal dialysis patient. The other thing to remember is all TAVR valves are similar as bioprosthetic valves, but their longevity is still not well known because obviously TAVR are relatively newer than the other bioprosthetic valves. Here are more pictures. So what happens to these valves over time, as into the bioprosthetic valves? So when we talk about structural valve degeneration, what does that mean? It can be due to calcification. It can be due to leaflet perforation or panas formation or just thickening, rigidity. So if you look at all the variable ways that these valves can fail. So what we can do about it? Either we can cut it out and replace it again with another tissue or mechanical valve, what we call it as a redo SAVR, or we can use one of the TAVR valve and do it as a valve-in-valve, which I'm sure Omar will talk about. Redo SAVR is what we used to do before TAVR comes into place. And this is important for us as surgeons because we need to start by putting a big enough valve so then it can accommodate a TAVR later. But however, that is not always possible. This slide is very important. So this study has showed the importance of recognizing that bioprosthetic valve, whether it is SAVR or TAVR, it will deteriorate and it will need reintervention in those under 65 years. And this is shown that this study particularly shows that this problem is significant even within the first 5 years if you compare it to mechanical valves. That's we are talking about the younger patients. The other issue we talked about is TAVR and bicuspid valve, which is still we don't know much about. We know some, but it's still in progress. We know it is not ideal. It's not an ideal solution. And it is, again, important if you have a patient with bicuspid aortic valve, because you need to look at the lifetime valve management in these patients. To finish up with, I just wanted to summarize it, 3 cases so we can have a discussion about it and it will help in decision making. I don't want to go much into details into guidelines, but we all know this is the American guideline, the European guideline. This one will guide our choice between mechanical and bioprosthetic. And here is guide us about the choice of TAVI versus SAVR. So start with our first case. 50-year-old woman has severe aortic stenosis. She has been told that a transcatheter procedure can be performed to replace the bioprosthesis when it degenerates. What would you advise her? So in summary, she has severe aortic stenosis, and let's assume she is fit and well, non-smoker. What do we do? So what are our issues here? The issues first, the patient preference, and if we follow the guideline that it would advocate SAVA with mechanical valve. If we go with tissue valve, we know that it will degenerate. There is 50% chance within 10 years at this age. Likely, as we said, with her age, it's likely to be bicuspid aortic stenosis, and this is not great for TAVR. So what are our options then? So we could either go with Ross procedure. What does that mean is we take the pulmonary valve, put it in the aortic position, and replace the pulmonary valve with a pulmonary autograft, but it's a highly specialized. It converts one valve to two valve problem, and it needs a specialized center, which we are able to do in the Austin, but again, it depends on availability of pulmonary autograft. So what if we go with TAVR now? We need to know that she will need either valve-in-valve TAVR in 10 years, and then another procedure before she is 85. But then if we go for a valve-in-valve TAVR explant as the second procedure, that carries 20% operative mortality. What do we do then? Mechanical valve will be the best choice, but patient preference still matters. So if patient still choose bioprosthesis, for this scenario, the best would be we go for a biosava now, then she will have a redo biosava second procedure, and then we save the valve-in-valve TAVR for the third procedure. Okay, second scenario. If we have a 73-year-old woman with symptomatic severe aortic stenosis and borderline small aortic root, her comorbidities are end-stage renal failure on hemodialysis, hypertension, dyslipidemia, diabetic ischemic stroke, cataract, psoriasis. So what are our issues here? She's 73 with all these comorbidities. So the most important factor here is her end-stage renal failure. How would that impact? We know that she will likely have reduced life expectancy. The candidacy for renal transplant will impact our decision and other comorbidities as well. So again, we have to think, what are our options? If we go with bioprosthesis, she will likely have accelerated structural valve degeneration because of the renal disease. We said they are more likely to degenerate. So what do we go with? Do we go with SAVA or TAVR here? Given her limited life expectancy, she's unlikely to require second intervention on the aortic valve. So if her anatomy is suitable for transfemoral TAVR, then in this scenario, TAVR would be preferred option. If her anatomy would not be suitable for transfemoral TAVR, then we would go with SAVR as a surgical aortic valve with a bioprosthetic valve. The last scenario, we have a 67-year-old female with symptomatic severe aortic stenosis and severe proximal LID disease. She's motivated, still working, independent. However, she is diabetic on insulin. She is also hypertensive, dyslipidemia, and obese with a BMI of 40. How about this case? What are the issues? So she's quite comorbid, but with optimal medical management, she's likely to live into her 80s. And also her LID lesion is a prognostic lesion, and it might influence her survival. So what do we need? We do need to do aggressive risk factor modification for sure. And what are our options? So same, either bioprosthesis, SAVR or TAVR are the same here. Litagraft to LID versus PCI to stent to LID. So these are the options. However, the proximal LID lesion, we know that the litagraft is preferred. So that means surgery is preferred for a proximal LID lesion. So what does that leave us with? Probably the best for this lady is for a surgical aortic valve replacement and CABG by one now. And in the future, she might need valve-in-valve TAVR if required later. That's all what I'm talking about today, and thank you.
Excellent, Fitoon. Thank you very much. It's 2 minutes over time, but that's lovely. I didn't stop you. I enjoyed your talk. Thank you very much.
Thank you. Sorry for that.
You're next. You put your slides up, present yourself, and go ahead.
Thank you. Can you see my slides?
Yes, we do. Thank you.
Right. Okay. So good evening, everyone. This is Omar Almukhtar. one of the cardiologists, interventional and structural, and I think I met most of you guys. I work out of Western Health and Royal Melbourne Hospital that I joined recently, where we do our TAVIs, and also privately at My Heart and Epworth and Richmond. And I just wanted to talk about the TAVI being the modern management for aortic valve stenosis. And the reason why I said modern is probably SAVR is still modern, but we obviously, as Fitoon said, we're doing more and more TAVIs these days. So it makes it really a modern option. Aortic stenosis, as we've heard just with Fitoon, is mostly due to calcific degenerative aortic valve stenosis. It is the most common pathophysiology. Bicuspid aortic stenosis is still an important group of patients, especially in younger patients having aortic stenosis. And symptoms in general, I think the general practitioners in the group here will also notice that mostly presents with shortness of breath, chest pain, or syncope. Basically, like we said before, the presence of symptoms indicate that we have a need for intervention. And what I really explain to my patients all the time is that having symptoms of shortness of breath, lack of energy, chest pain is not part of normal aging. It indicates the presence of a problem that we really need to look for and treat. This is one of the very earliest slides since the invention of echocardiography. I think since we started recognizing the importance of aortic stenosis in the late 80s, we saw that aortic stenosis is a condition that develops over 5 to 20 years. And over that period of time, patients have no symptoms. And this is the golden time where we can actually start recognizing it so we can follow the patients up quickly and start really probing options, whether we should refer them on to see a cardiologist yet or not. Because once we have symptoms, we have very limited time in terms of what the patient has before they actually have very poor outcomes. Once they have really the angina symptoms, they have 5 years to live. Once they have syncope, they only have 3 years to live. And once they have heart failure, they only have 2 years to live. And this is very important really in general practice to recognize that to really help us with early referrals. In terms of diagnosis, like we said, basically the first step would be the history examination. We all do find harsh systolic murmurs, and echocardiography is very important to consider when the exertional symptoms presents in a patient who is in the elderly. But what is TAVI? And that was just a very small introduction, so we can talk about TAVI quickly. It's minimally invasive option, modern for aortic valve replacement. It's keyhole surgery, and I think that's a key word that we can always use is keyhole as opposed to the sternotomy that we can have with a surgical aortic valve replacement. It's performed by structural cardiologists in cath lab. There is no sternotomy scar, and this is important to the patients to really recognize. And normally we have the valve options being only bioprosthetic. We cannot put a mechanical valve via TAVI procedure. Very important, like Fitoon was saying, part of the description of the patients who have aortic valve stenosis is that we need to determine what we call surgical risk, which means what is their overall risk should they go for open heart surgical valve replacement. And this is a very complicated process. It used to take into account only the comorbidities, but I think over the years and with the invention of the heart team discussions, we recognize that determining the surgical risk of a patient relies on multiple factors, starting off with the demographics, with age being one important factor into the demographics, but also the anatomy, whether somebody has a tricuspid valve versus bicuspid valve. The overall frailty is an important part of the discussion to determine what a surgical risk is for a patient. A 65-year-old man who is frail probably has a lot higher risk than a healthy, robust 80-year-old. So frailty on its own is probably one of the most overlooked components that we should be using in determining surgical risk, along with the comorbidities, traditionally being diabetes, chronic disease, and chronic airway disease. But also, more importantly, there is more and more focus on the patient choice and the patient preference in terms of what procedure they're going for. So with TAVI being a keyhole surgery, we often just gain access via the femoral artery, but we can still use other arteries such as the axillary artery or the carotid artery. This is the glue bit, that's the delivery sheath that can deliver the valve. As you can see, the valve has been delivered here to the aortic annulus using the delivery sheath, and then using the deployment maneuver, we just deploy the valve and then it's left. There is in Australia multiple valves that are available as TAVI valves, but you probably, if you see the reports coming after TAVI procedures, the two most commonly performed TAVIs will be with the Evolute valve, which is the one here on the left-hand side, having the classical crown-shaped valve, and also the Sapien valve. Evolute valve is made by Medtronic, and Sapien valve is made by Edwards. They have, in terms of the material they're made from, usually it's a nitinol mesh, and then they are using the bioprosthetic material used from the coverings or the pericardium of the either the cow or the pig, depends on which valve we're using. When I discuss the possible complications with TAVI procedures, I call them the big five that always really mention to the patient, including the risk of a stroke, bleeding, heart block, renal complications from the use of contrast. I must admit, with the advances that we are having with the TAVI procedures, we're seeing less and less renal complications as we're using less and less amount of contrast. And then eventually we can always more risk of having what we call aortic valve regurgitation if the valve is not filling the whole annulus level. So who's TAVI in 2025? Basically, patients above the age of 70 or 75, I would argue most of them should have TAVI. Patients who have moderate to high surgical risk after the implication of all the complex process in assessing their risk, any frail patients with comorbidities. But now we have expanding indications. More and more patients are becoming appropriate based on the most recent guidelines. How do we work up someone for TAVI? It basically starts by the suspicion raised by the general practitioner as they see patients presenting with symptoms that could indicate underlying severe aortic stenosis. We'll need the transthoracic echo to confirm the severity of the aortic stenosis, and then the patient will be reviewed by a cardiologist who can perform the procedure. We do the workup, including the CT TAVI to confirm the anatomical suitability, and we also perform a coronary angiogram. And then after that process, we go to the heart team to confirm that we think TAVI is a better option for this patient as opposed to SAVR. Sometimes we think SAVR is a better option, but eventually TAVI will have to be performed a TAVR procedure, and then we'll have yearly follow-up. Unfortunately, this workup process in this day and age in Australia takes on average 9 to 12 months, which means many patients might not make it to have the procedure done. As we showed, like in the very earlier slides, once patients start having symptoms, they have very limited time frame. So all the efforts between the general practitioners to the specialist, cardiologists, and the surgeons should be focused on really minimizing the length of this process, trying to achieve the best outcomes for the patients. What do we tell the patients once you really start having that discussion about TAVI? It's usually an overnight stay in the hospital, done under general anesthetic in most centers. However, some centers do it under local anesthetic. Patient will be discharged home within 24 to 48 hours, and most patients love this fact. And what I really consent my patients for is usually the following risks. I would say the highest risk after a TAVI is the risk of requiring a pacemaker insertion, which is around 5 to 7%. There is a risk of a stroke being 5%, vascular injury about 2%, and the risk of death is less than 1%. And if you compare those risks with patients going through SAVR, to be very comparable with slight differences depending on the population. Very quickly going through the evidence behind TAVI. I think TAVI is one of the very few equipment or medical interventions that have gone through so much scrutiny over the last 15 years. So with the first partner one trial about 15 years now that really assessed the benefits of TAVI in high-risk frail patients, that demonstrated that TAVI was a safer option in the short term and mid-term compared to SAVR. And then moving on to the partner 2 trial where assessed the benefits of TAVI compared to SAVR in intermediate risk patients. And more recently, about 5 years ago, we started having the evidence with TAVI compared to SAVR in low-risk patients. We also now have had multiple studies to tell us that TAVI is a safe option even in low-risk patients. And that was the main reason, like Dr. Fitoon has shown, that we are performing more and more TAVIs over the last 5 years compared to the last 15 years. Quickly, how to do it. On the left-hand panel, as you can see, this is just the pigtail catheter in the aortic root. and we're just doing an aortogram in the beginning of the procedure. Before the contrast goes in there, you can appreciate how much calcification there is in the aortic valve, indicating the severe underlying stenosis. And then once we deliver the valve is usually mounted on a balloon. And once we have achieved very fast heart rate using temporary pacing wire, I can appreciate here, the valve is inflated and is deployed in place. And at the end here, you can appreciate after we've done an aortogram that there's a well-functioning valve. This process nowadays takes about 45 minutes. So it's a procedure in the right setting with a good planning, can take 45 minutes. The patient can go home the next day. Valves would not last forever. We know that for both TAVI valves, but also for SAVR valves. So what do we do when a TAVI valve fails? And usually I would say the life expectancy for the current generation of TAVI valves is about 10 to 20 years. There is always the option of putting another TAVI valve within the old TAVI valve. So on this patient, they've had the first valve was the Evolute valve, as you can see this from the crown shaped valve. And then we've gone in and put in another Sapien valve within the old valve. And again, the valve is inflated with the balloon. We just deploy it in the right plane, which is the right annular plane. And within less than an hour, we have another valve and valve. So one TAVI is not a good option. Usually, as Dr. Fitoon has said, young patients, younger than the age of 60, they are appropriate for mechanical valves that would last them their lifelong. Then TAVI is not a good option. If somebody has concurrent severe coronary disease not suitable for PCI, then TAVI is a good option. Bicuspid aortic valve stenosis, I would argue that SAVR is still a better option given the high risk of a stroke. And also in patients who have other significant valve disease, patients who have aortopathy, dilated ascending aorta, where other things needs to be fixed during the time of surgery, then just doing TAVI is not going to fix the other valve problems or the aortopathy problem, then SAVR is a better option. And on rare occasions, the anatomy is just not suitable for TAVI. The TAVI could be really high risk procedure in some patients, for example, who are at risk of acute coronary occlusion. So in summary, in Australia and CIS 2023, we are performing more TAVIs than SAVRs. I think last year we performed about 4,500 TAVIs as opposed to 4,000 SAVRs. Every patient in 2025 should be assessed whether TAVI is an option, especially those patients above the age of 60 before we commit them to stenotomy and SAVR. The risk and complications are reducing in incidence, and this comes with the more experience we have. Now that we're performing thousands of procedures every year, we continue to learn and we continue to improve the techniques. And the durability is also something that's improving over the years. Now we can confidently say at 10 years, a TAVI valve will perform as strongly as a SAVR valve. So if someone is above the age of 65 and they're being offered a bioprosthetic surgical aortic valve replacement, I would strongly argue that TAVI is a better option if they're going to have a bioprosthetic valve because they will perform as well as each other. In the near future, most AS patients will receive TAVI. So thank you for listening.
And thank you very much, Omar, for the talk. You are 3 minutes over, but that's fine. Yeah, then the floor is open for questions. You can unmute and ask the question if you like, or you can write your questions in the chat. All right, if there's no questions, I can start the questions by asking, we hear more and more that TAVI these days can be done for moderate aortic stenosis. So what do you think, Omar, by this?
Yeah, thank you, Dr. Ali. There's more and more evidence, especially since the recent trial published, is that intervening on moderate aortic valve stenosis, most patients who do not have the intervention will turn into severe by 12 months, which means they will end up having the procedure anyway. Patients with moderate stenosis who have TAVI, they're at lower risk of decompensating with heart failure, and they have better quality of life with equal risk of complications. So honestly, I feel in the next 2 to 3 years, in the very near future, we are moving into expanding the indication for intervention for aortic stenosis, whether it's SAVR or TAVI, into the moderate stenosis. We're just waiting on more evidence. So far, we only have one randomized control trial, but I think we're waiting on 2 or 3 right now to finish recruitment before we have enough evidence for the guidelines to change. What do you think, Dr. Fitoon? Is there anything from your perspective with moderate stenosis?
I think what concerns us is just, as I mentioned, the lifetime valve management. If there is indication for surgery, whether if it is, even if it is moderate, whether it is TAVR or SAVR, then yes, I agree, the patient should go ahead. But it's just from our perspective, we just need to be mindful of how many more procedures this patient might need. Say, if a patient is 60 or 61, let's say, and you expect them to live until their 80s, if they are expected to need 2 more procedures, then maybe not to go for TAVI in the first instant and save the TAVI for the second procedure. That's what we really try to emphasize. But yeah, for the moderate, I agree. If patient needs it, then it might not be different whether you're going for a SAVR or a TAVI.
Excellent. The second question I have also for both of you is the low flow, low gradient. Can you explain to me what's the low flow, low gradient aortic valve stenosis, and how do you assess the significance of the aortic stenosis in this case?
Yeah, Dr. Ali, very tricky question. I don't think many cardiologists will even agree on one answer on this one. I, for one, is skeptical with this concept, to be honest with you. The whole concept really belongs to the fact that if there is a low flow of volume across the aortic valve, then the gradient will be low, but the valve is still severely stenosed to the degree that it will give symptoms. From my perspective, I've seen patients undergoing valve replacements or TAVI when they have this so-called low flow, low gradient, and at the end, they don't have much symptomatic benefit. In terms of how we assess it, there is different ways, really. I think invasively doing a right heart study, trying to see whether there's any degree of pulmonary hypertension, any degree of decompensation with BNP testing. If the patient have presented with heart failure, might put a little bit more weight behind the intervening. But I remain personally skeptical about it. What do you think, Dr. Fitoon?
Yeah, so this sometimes we do functional assessment, dobutamine stress echo, or even like we put the patient on a treadmill and see what happens to the gradient across the aortic valve. So it's all I believe it's all to do with multidisciplinary team talk and chat and whatever we come up with. But by the end of the day, I think a functional assessment, dobutamine or a treadmill, can be, if determined that the patient becomes symptomatic on the treadmill or with the dobutamine and the gradient increased across the valve, probably that's an indication. Ahmed, I think Dr. Ahmed, عندك سؤال?
Wallahi, but yes, Dr. Fitoon, thank you very much for the excellent presentation. And Dr. Omar, my question to you is this preference of warfarin over NOAC, is it a data or evidence-based, and what mechanism difference between both of them, which makes
it is evidence-based, and there is they tried the PROACT trial, they trialed NOAC, and they had to stop the trial early. They did not even finish the trial because there was a much higher rate of strokes with NOAC in comparison to warfarin. So for mechanical valves only, NOAC is contraindicated. It has to be warfarin. Why? I don't know. I don't know why, but like even when they trial, that was short, but I don't know why. I don't think anyone knows why. I don't know. You can correct me, Dr. Ali, but I don't know if anyone knows why, but we know NOAC is contraindicated. It doesn't work.
Yeah, it's a different pathway. Well, the risk of aortic valve, the mechanical aortic valve thrombosis, to be honest, is still small anyway. So we're talking about patient even without warfarin. They still sometimes, in some cases, we don't advise patients to stop the warfarin anyway, but the risk is still small. With the mitral valve, mechanical mitral valve, the risk is very high because the gradient across the mitral valve is low. But the risk of aortic valve thrombosis, mechanical aortic valve thrombosis, is still low. The difference between the two is a different pathway. And we believe, based on the studies, warfarin works better. That's the only explanation we have so far. We don't have any. And we can't really answer the question more than that.
Exactly. Because it's just for this indication, right? So on the wide spectrum, I don't think there is much differences there.
It's not just for this indication. In case of severe mitral stenosis, NOAC still not indicated. warfarin works better than NOAC.
Yeah, that's
So
involved.
there's two cases, mechanical aortic valve and severe mitral stenosis, and also LV thrombus. So in patient with apical aneurysm, left ventricular apical aneurysm with a thrombus present, warfarin works better than NOAC. And in some cases, if patient on NOAC and they develop DVT or pulmonary embolus, they change to warfarin. So there are some cases when warfarin works better than NOAC.
So for interventional in other discipline there, how long you can just sit on the patient without warfarin waiting for an intervention? And is bridging with NOAC of any help here? Or?
No, you would usually, yeah, sorry, you can
No,
take
go
it.
ahead, Fitoon,
Yeah.
sorry.
I mean, if you are bridging, if you are waiting for a surgical intervention or any sort of intervention that requires stopping warfarin, then you wouldn't bridge to NOAC, because NOAC you need to stop it as well. So you would usually bridge to either therapeutic heparin or like unfractionated heparin or low molecular weight heparin.
Right.
I might just add to this, like usually in the non-cardiac procedures, and Fitoon, maybe you correct me if I'm wrong, but with the mechanical aortic valves, usually it is safe to be off warfarin for a short period of time, as opposed to the mitral valve, which we are very more careful with regards to the interruption in anticoagulation.
That's right, especially, but it depends on which valve of the aortic. Like, say, if you have onyx mechanical valve, then you would even have, you will be less worried, much less worried in comparison to other mechanical valve. But if we are giving advice to a primary health physician, then we would say always ask before you make that decision.
And just to add to this, in some cases, if we do angiography, for example, not necessarily we need to stop any of the anticoagulation. Some cardiologists still not that keen on keeping patients on NOAC or warfarin when they do the procedures, but because we do more and more radial approach, and radial approach is much easier to control bleeding, we do these procedures on anticoagulation. We don't stop them. And even if you got femoral procedures, we usually use ultrasound guidance and we use a closure device. So we're happy in most cases to go ahead and perform angiography while on anticoagulation, mainly NOAC. With warfarin, we prefer the INR to be tested, and we prefer the INR to be about 2 or less, just in case. But generally speaking, we can perform procedures, vascular procedures, without stopping any of the anticoagulation anyway. Samer raising his hand. Do you have a question, Samer?
Yes, thank you for wonderful presentations, both Dr. Fitoon and Omar. First of all, it's the first time I see an Iraqi cardiothoracic surgeon, so I'm very excited to know Fitoon, and her presentation is excellent. بس احنا نحب نداها. فسؤالي هو, why is it that we have to do an MDT consensus on a TAVI valve for a patient who is above 70 when the evidence is clear that a TAVI is non-inferior to open cardiothoracic surgery, as opposed to someone in the community referring an AS to the surgeon and they can just crack on with the valve? They do not need an MDT. Any thoughts?
I guess it's, hello?
Yes,
Can you still hear me? Yeah.
I
think it is still, I believe it is important. I emphasize the lifetime valve management with a TAVI. So if you say someone is 70, and it depends on what is the aortic root size. Do you think this patient might need an aortic root enlargement? What size of TAVI valve you can fit in? So say you could only fit a 20, what's the smallest size you have? The 23 will be with the TAVI, right? Similar will be the 23.
There's a 20 Edwards or 23 Evolut, yes.
Yeah, so if you go with that, then if this patient might need another valve in valve if they live into their 80s or 90s. So then you might be compromising their second procedure. While if this patient now 70 and you can go and get an aortic root enlargement and put a reasonably big enough size valve, say you can put a 25 or 27 valve, then for the second procedure, you can easily go in with TAVI. So I think that's why it is important. It's not for why we are doing it for surgery or not for TAVI, but it's just because for the lifetime valve management, if you discuss it on MDT, then you'll have input of both the structural team, the cardiology, the surgeons, and obviously with the input from the primary health
It's a
physicians.
great point, lifetime management. So the durability of TAVI valves in the Notion trial, which is the longest follow-up, the TAVI valves were more durable than the surgical valves. So I guess apart from the small annulus, because we always use CT for sizing, so if we have a size that's 26 valve or above, you can technically fit in 3 valves down the track. And on an average of 10 to 15 years, that can take you to 45 years longevity. So for me, it's still a bit difficult to grasp. And it's the same concept, but basically if on that premise alone, if you have a big enough annulus, you don't need an MTT for TAVI. You can just go ahead as well.
How many 3 procedures valve and valve we have experience with so far?
Very little.
That's the thing.
How many
How many as third
how many thirds do not
valve and valve? Oh, plenty.
Yes.
Plenty. So that
Plenty
is, I
that
think
didn't
that,
make it as well, right?
but that, I think that what makes it is how much, like with time, this might change. You're right. But it's just our knowledge so far with this. But until we collect the knowledge and information, that's why we need to discuss it to be on the safe side. But
That's
before
right.
TAVI, we didn't have TAVI, right? We
But
didn't
I
have,
have to say,
but then we have TAVI now.
the surgical literature is limited in terms of follow-up of valves. The valve durability is based on benchtop testing, and the surgical data, including the Australian registry, doesn't capture long-term. So what I would like to do, Fitoon, we like you so much, we would like to invite you to the cath lab and you take on TAVI as part of your career. And I think you will be the first Iraqi cardiothoracic surgeon who also does TAVIs in Australia.
That's good.
Excellent. Well, that's why we have a debate, and nice to have a debate. We have the view of the cardiologist and the cardiac surgeons on doing, but I still believe surgical aortic valve replacement, transcatheter aortic valve replacement, they're still there, they're still valid. We need them both. I don't think we can just say, well, TAVI is enough, we don't need any more surgical. We still need you, Fitoon, to do surgical approach, and we still need Omar and Samer to keep going with the TAVI. Look, thank you very much. It's 8:44. If there's no more questions, we bring the meeting for, we conclude, we finish tonight. Any more questions? Excellent. So the next meeting, hopefully we can organize one in about 4 weeks. So hopefully around mid-July. I may speak to media.
We have already, Doctor, we have already 2 topics online.
Okay, yeah.
One in the plastic surgery, and one we having on dermatology. So we need some variety of topics here.
So beautiful. Can we say in about 4 weeks' time from now?
Yeah, 4 weeks. Yeah. We might have the dermatology there from both specialist and GP perspective. So that will be the next one, I think.
Excellent. We'll have a chat offline later.
Okay.
So thank you very much, everyone. Thanks, Omar. Thanks, Samer.
Thank you, everyone. Can I just quickly say just one thing? Thank you, everyone, for the wonderful presentation. I will be presenting in a community education session for women on the 5th of July. I will put the floor